course. So tell us about how long you've been a pharmacist, and tell us currently about your current position as a pharmacist now.
Okay. So going on 5 years as a pharmacist, really only the last 4 that I've really been practicing, because my first year was residency. So right now I'm a clinical pharmacist at Scott Air Force Base, and then faculty. So you want more of the focus on my clinical pharmacy role. So I know one of the questions was percent patient contact. I'm 100% patient contact. So I'm running patient clinics.
And what does that even mean?
So I have diabetes, cholesterol, and anticoagulation clinics.
What was the last one?
Anticoagulation,
Okay.
like Coumadin or warfarin, blood thinners.
Okay, I see.
So I have over 200 patients that I manage, and so that's my role is down from education, management, monitoring, just continual care with these patients along with their regular provider.
Okay. And so, just for purposes of making sure that Min understands, when you see a patient, typically what are you doing during that interview or during that session?
If they're an initial patient, I'm educating them on whatever their disease state is, primarily for the initial couple visits. Follow-ups are more based on management. So what goals we're trying to attain, what changes in their medications I'm making, why. Just making sure they're fully educated on what they're receiving and why, and what goals we're continuing to work towards for whichever disease state I'm seeing them for.
Right. Okay. And so you totally manage these diseases, and so it's a little different than what other pharmacists may do, because usually it's in collaboration with the physician that they may make recommendations for changes.
Oh,
but
so you
Stacy
don't?
actually makes
I do.
those changes.
How does that work?
I'm at the Scott Air Force Base. Federal
Okay.
pharmacists can prescribe.
Oh, cool. Okay.
So that's definitely a different different aspect of it. And so, we were just talking about the future of pharmacy, and so I think this is where pharmacy is heading, where we would be considered mid-level practitioners, such as nurse practitioners, and being able to prescribe medications and actually manage the patients versus just making those recommendations.
Right.
Okay. All right, so those are the responsibilities. So what are your goals during the direct patient encounter? I know you said education, but are you just wanting to provide them with information, or are there any other goals that you set during your patient encounters?
Almost every encounter is kind of us coming up with an agreement. I know what my goals are for the patient. I need to know what their goals are, and then we have to come to an agreement. So I may want them with perfect numbers. They may not care so much about the numbers. So it's every appointment's kind of, what are you wanting to achieve? And then we come up with ways that we can meet those goals, whether it's changes in medications, me talking to them about their diet, whatever it takes. But then anytime I make changes, I do make sure they know why. So educating them on new meds, what to look for.
How is that easy to achieve? Kind of making sure that you come to agreement. You have your goals, they have theirs.
Not always, because I have a lot of patients that just don't care. So it's me trying to convince them to care.
Okay. And you bring up a good point. Kind of tell us about your patient population.
Yeah.
It's pretty mixed. As far as for my anticoagulation clinic, I have a very good mix of active duty patients, so they're actively in the military. And then I have retiree patients, or I have spouses of either they've retired spouses or spouses of active duty. So, I mean, at any given time, I've got ages 16 to 90 is my age range for the clinics. Now with diabetes, I don't have near as many active duty patients.
Because they're older?
More so because it depends on their job risk, but if they're on insulin, that eliminates a lot
That's
of their
right.
responsibilities in
Makes
the Air
sense.
Force.
Yeah, that makes sense.
Okay.
So it's a wide mix.
It is.
Okay. So you said that one of those things is that patients do not care, which obviously is a struggle. What do you do when if you obviously tell us about?
A lot of education of what could happen. So I guess a friendly scare tactic of I don't want to scare you, but if you don't take control of whatever the disease state is, here's all the consequences. And I have a lot of people that just say they don't care because there's too much else going on in their life, and so I kind of take the route of, I want you to stay around to help your grandchildren, and so convincing them.
How do you build relationships with your patients?
I'd say mostly being personal on the interviews. So I follow a lot of them weekly, but the most is probably once a month that I'm following these patients, so I get to know their lives, their families, their vacations. And so we talk a little bit about that. We mix a little business with pleasure so that they trust me, because I'm asking them about their son's wedding or most recent trip, but then we get down to business.
Right.
So, how long are your sessions normally?
For like anticoagulation, it's a 15-minute appointment. Diabetes follow-ups are 30 minutes. If it's a new patient, up to an hour.
What skills do you have to effectively communicate with your patients?
I don't know. I would say more just the personal communication, the comfort level where they feel comfortable opening up with me. I don't know a correct term for that.
Well, you talked about being friendly. You talked about getting to know them at a personal level. Right. I bet those all help. Yeah.
Yeah.
What about skills that you wish to improve to effectively communicate with your patients? You want to either improve, develop. You may notice there's certain things that need to be addressed more based on your experiences. I think I kind of want you to also talk about your residency experience, because that was with a different patient population, and so let's kind of backtrack and tell us about that patient population.
It was completely different. It was an underserved population that seemed extremely grateful for any care they received.
Tell us where it was.
It was in North County, St. Louis, at the health department, where I had a cop walk me to my car every day.
You had a what?
A cop walk me to my car
Seriously?
every day. It was not in a good area.
Oh, okay.
But a very underserved population that, like I said, was extremely grateful for care. So anytime I educated them, they were extremely grateful. They'd never heard this before. Any samples. I mean, we had a limited formulary compared to now I'm working with a unlimited formulary. Mixed population, the active duty population I have, they have to come and they have to care, or they could potentially get kicked out of the military.
Oh, okay.
So they care, but then I have the mix that they've got free health care for life, and they're not as, I guess, grateful for all the good care
Right.